The effect of grip training with prototype silicone dynamic finger wrist retraining aids on grip strength and wrist flexor tension in patients with chronic stroke. Introduction. Strokes are caused by ischemic infarction of the brain and cerebral hemorrhage. Stroke patients have difficulty living on their own due to severe motor disorders caused by chronic disorders such as motor function, cognition, perception, and sensation. In addition, most patients have upper function problem after stroke, and patients with severe upper limb muscle damage have a very high risk of cramping their arms. In addition, as stroke progresses to chronic, the patient's hand and wrist are bent constructions, and problems with this construction usually occur between 6 and 8 weeks of stroke. The contracture and paralysis of the upper extremity bring great restriction on daily life. There are significant restrictions on washing, dressing, eating, and wheelchair use, and if proper attention is not paid to the patient's finger, joint, and surrounding soft tissue, shortening the flexion of the hand will result. Cramp and contracture are the biggest complication that cause exercise restriction after stroke, and stretching is very important to prevent such cramp and contracture. Muscle must be stretched at least 6 hours a day to prevent muscle buildup. And orthopedic surgeon recommend long-term sprint to prevent buildup. However, the effect of these sprints are limited by several studies, and there are many stroke patients who clinically cannot withstand static stretching for more than 6 hours a day. About 50% of stroke patients are reported to be unable to perform static stretch for more than 6 hours due to discomfort. Also, when stretching for a long time through static devices, pain stimulation in the hand and the lower arm can increase spasm and in the wrist and finger, and constant wear of the aids can cause pain and pressure ulcer. It is assumed that this pain and discomfort will be caused by one static device and a change in the degree of the compression on the other. At the moment of severe cramp, the wrist is tightened and the sensuous pain stimulation increase pain, pressure ulcer, and muscle tone. At other times, the wrist may relax and leg stretching. If static or spastic are not well tolerated, shrinkage may occur, and more active interventions such as botulinum toxin treatment and surgery are needed to prevent clenching of fist. In addition, the continuous wear of static aids can lead to multiple impairment to the patient's muscle, particularly problems such as cramp due to increased muscle tension and loss of muscle elasticity. In addition, joint and ligament contraction can occur, resulting in loss of the mobility of joint wearing static aids, and problem in joint and ligament contraction further interfere with muscle function. In particular, hand spasms are destructive, so improving shoulder and or elbow function may not be appropriate to ensure overall functional improvement of the upper limb. Previous study also used various outcome measurements for upper limb function and conduct training for fewer study focused on hand movement. Some hand restoration study include injection of PTXA and other drug into muscle or through electronic stimulation. For leg study confirming the conversation of the hands flexor muscle through training. In about 60 to 70% of patients with stroke, dysfunction of the upper extremity is reported, and in 20% of the survival of stroke, daily life is reported to be dependent on help from others. For everyday life in stroke patients, this dysfunction of upper extremity is considered one of the biggest obstacles and is a problem that should be studied by many researchers now and in the future. The upper limb consists of the upper arm, lower arm, and hand, especially in the hand, which we perform functional activity through delicate movement. For the patient's daily life, hands are used in all kind of movements such as eating, washing his face, shower, dressing, cooking, and cleaning. And hold the hand is especially important to do this. The grip consists of the strong grip and the precious grip. And the hook grip and the action of the thumb is very important for all other than hook grip. In the case of pickup, it is used through the thumb and index finger for movement that requires subtlety, such as key, needle, pencil, and chopstick. Sufficient muscle strength is essential to perform this functional movement, and muscle tension to which the muscles can contract is important. If you don't have enough muscle strength, you can't hold object or maintain motion. If muscle tension is too low, you can't produce muscle contraction, and if muscle tension is too high, you can't perform functional motion because it prevents joint movement. Therefore, securing muscle tension and strengthening training are one of the most important factors that can create functional movement in stroke patients. According to previous study of the elderly, grasping power represents the health of the individual. Another study report that decrease in women's grasp power was associated with decrease in bone density. Catching strength has been found to be useful in predicting premature death. Early development of disability, post-operative complications, post-fracture hospitalization period, and cognitive decline in older adults. Study on the relationship between grasp power and perception evaluated cognitive function in 76 elderly people using clinical dementia rating. Mini mental state examination Korean version, MMSEK, Lawton scale, and evaluation of activities in daily life. Because reliability was shown to be appropriate for grasping strength, assessment based on grasping strength were reported to be applicable not only to baseline dementia patients but also to patients with mini and severe dementia. A study of older Mexican Americans shows that people with weak grip tend to get a low score in MMSE over time. Neuroscientifically, training peripheral movement repeatedly and task-oriented promoted neuroplasticity in the brain, which in turn increase peripheral movement performance. With this theory, physiotherapy method can be applied uh, effectively to stroke patients. Also, strengthening muscle strength is uh, only possible through resistance movement. Uh, Passive or active exercise can maintain the working power of the joint and secure elasticity of soft tissue, but it is important to strengthen muscle strength. Therefore, it is recommended for patients to use assistance for training or for short-time task performance because the use of assistance can reduce the performance of the patient's muscular strength and in the long run. In this study, we investigate the effect of the application of hand trainer to silicone grip strength and muscular tension in stroke patients to suppress cramping of the hand and finger muscle in patients and to maintain muscle elasticity. Therefore, this study proposed another method of hand strengthening exercise equipment to enhance the hand function of stroke patients and seek to see the effectiveness of the newly constructed trainer. Traditional hand aids used in the past were used for simple straightening or fixing, and spring-based aids were very uncomfortable to detach and complicated in their structure, making them difficult to use and causing frequently failure. Therefore, we proposed a new type of silicone hand trainer that is easy to detach it and allow patients to easily perform and strengthening training. For this experiment, we recruit the patient from big hospital in Korea. The include criteria were first patient with stroke over 6 months, second prostrone stage 3 to 5, third hemiplegia with age, fourth ability to understand and follow verbal instruction, fifth ability to walk over than 10 meters without assistance. Sixth, patient without psoriatic disease on the upper extremity. And seventh, mini mental state examination Korean version. Score is of not less than 24. The exclusion criteria were upper limb functional problem caused by vision, hearing, or vestibular disorder, and other neurological problem unrelated to stroke. According to the inclusion and exclusion criteria, total of 20 patients, including 15 men and 5 women, were recruited. The average age was 60.32. The average height was 168.53, and the average weight was 65.33. The average MMSK score was 27.23. Cerebral infarction is a type of seizure in all patients, and average time elastic after stroke. The 11.23 months. Discussion. Stroke patients suffer from muscle weakness, cognitive dissonance, and self-acceptance sensory disorders throughout the body, causing balance, coordination, and dysfunction. This study examined the effect of hand bending training on the muscle strength of the hand and muscle tension of the hands through the newly made silicone hand aid. Due to the nature of silicone materials, they are suitable for stretching and resistance training. Currently, silicone is used as a tool material for rehabilitation training such as TheraBand and Zimbal, and depending on the degree of elasticity. It has the advantage of being able to apply various resistance force to user. Also, it is good to use for the long time due to its high durability, and it is easy to use due to its simple structure. Silicone can also apply structural pressure, which can cause sensory stimulation by applying pressure to the fingertip. In order to verify the very effectiveness of the prototype product, simple repetitive training of holding and stretching the patient's hand was conducted, and the resulting increase in muscle strength was confirmed. Although the increase in muscle strength was not significant enough to affect the patient's daily life due to the short time of training, it is believed that if the patient is trained for a long time, the patient will obtain significant value that can affect his daily life. Currently, used trainers were manufactured using silicone making mold instrument by mass production. As a result, the effectiveness of training could have been low because it did not reflect individual difference in patient, but it should be possible to conduct customized training for patients by diversify the size in the future. It is also effective that the training effect would have been different depending on the physique capability of each individual, because all of the elasticity of silicone was applied constantly. In the case of muscle, active exercise should be utilized for the maintain of muscle elasticity. Passive exercise is used to maintain joint mobility, and the resistance movement can change muscle tension and muscle strength. Therefore, it is necessary to wear them for a short time and improve the remaining strength through resistance training, because the rigid static aids cause joint construction and reduce muscle elasticity. Muscle are controlled by nerve, but reconstructing damaged part of the nerve is possible through muscle movement. Previous study has shown the dynamic aids have less pain in patients than static pain aid, and the risk spasm increased in patients who were static aids for a long period of time. This can be said to have adverse effects on patients due to increased muscle tension. We must address some limiting factors in this study. The sample size of this study was small, and the results should be confirmed in a a large study. However, even this small group was sufficient to show a significant effect of wrist and finger bending muscle length. It should be noted that this study was the first to investigate the durability and effectiveness of newly developed dynamic orthography. Furthermore, it was not possible to consider changing in the patient's living environment because of patient comparison were made. A future study that control certain variable can produce a stronger result. The results suggest that the use of dynamic orthopedics in stroke rehabilitation is promising, and further research on the effectiveness of dynamic orthopedic use is needed. Thank you.